في الأول أحب أشكر أستاذي العزيز الأستاذ الدكتور محمد عوض تاج الدين رئيس الجمعية، وأستاذتي الفاضلة الأستاذة الدكتورة سميحة عشماوي سكرتير عام الجمعية والمؤتمر، ومرحب بحضراتكم السادة الحضور والسادة الضيوف. موضوعنا النهارده عن pulmonary perspectives in lung transplantation. Objectives pre-operative assessment for lung transplantation, early post-operative follow-up, and late post-operative follow-up. First human lung transplantation was done by Professor James Ferdy in 1963 in United States of America. Patient lived for 18 days and died from acute renal failure. This is the first attempt. Lung transplantation continues to grow as a field with more than 4,500 transplants performed worldwide in 2019 at over 260 lung transplant centers. Median survival is 6.7 years for adults who have undergone primary lung transplantation. The main cause of death after adult transplantation, acute graft failure, infection during the first year, and chronic rejection in subsequent years. Acute cell rejection and the infection with subsequent development of chronic lung allograft dysfunction remains a significant cause of morbidity and mortality after lung transplantation and a major limitation to long-term survival. First, of preoperative assessment for the recipient. This is a checklist, should be done in priority, ordered firstly by APO compatibility HLA typing, down to PET-CT if needed, and cardiological, cardiosurgery, and psychiatric consultations. This list of laboratory tests of preoperative assessment for the recipient and the cultures, as you see here. This list for the donor, checklist preoperative assessment, also ordered in priority, starting from blood grouping and HLA, ended by ocal balloon stool and the cardiology psychiatric consultation. This list of laboratory investigation for the donor, post-donors. Second is the early post-operative follow-up in the first 2 weeks. First of all, chest X-ray should be done daily for 2 weeks after transplantation, 2 to 3 times per week until 4th week after surgery, then once a week after the 4th week till discharge, then once every 2 weeks after discharge. Cultures including sputum, nasal swabs, pharyngeal urine culture daily for 2 weeks, then 2 to 3 times per week until discharge, then every month after discharge. Infection within the first months of surgery are mainly hospital-acquired bacterial infection. Bronchoscopy. Bronchoscopy during intubation in the first 5 days after transplantation should be done twice a day for confirmation of bronchial anastomosis healing and removal of secretions. After extubation, bronchoscopy will be done if it's clinically mandated, as there is a controversy between surveillance bronchoscopy and the clinically mandated bronchoscopy. It differs between different centers of lung transplantation. It's controversial. Risk versus benefit ratio, as lung transplantation centers vary widely in their practices, particularly since there is no clear consensus on bronchoscopy frequency. Transbronchial lung biopsy, if clinically necessary, should be done. At least 5 or more transbronchial lung biopsies are collected from transplanted lungs. Also, bronchial lavage and bronchoalveolar lavage, which is a liquid sample of the lung, it's important for diagnosis of many infections. Lung function test, PFAR, which is peak expiratory flow rate, measured at bedside, firstly as early as possible after surgery. Before discharge, spirometry should be done. Any decrease or decline by 10% or more in FEV1 or peak expiratory flow rate from baseline should be early signs of acute rejection. Avoid taking bronchodilator before the test for accurate results. This is the value of FEV1 after transplantation, classified as follows from stage 0 to stage 3, depending on the measurement of FEV1. Stage 0, 80 to 100%, stage 1, and stage 2, and stage 3. Antibiotics. It's preferred to start the empirical surgeon cephalosporin plus vancomycin and wait for the results of the bacterial cultures. Antiviral agent including ganciclovir by 5 mg per kilogram intravenous every 12 hours for the first 3 weeks, then shift to valganciclovir 900 mg tablet daily for 1 year. Immunosuppressive strategy. We should start by tacrolimus, Prograf. Dose is 0.5 mg per kilogram twice a day, 9 a.m., 9 p.m. Trough level should be between 10 to 20 nanogram in whole blood at 7 a.m. Cyclosporin, which is sandomune, could be used as a substitute to tacrolimus, not with tacrolimus. Tacrolimus or cyclosporin, dose 15 milligram per kilogram per day, twice a day. Trough level is 250 to 350 nanogram per milliliter. Mycophenolate mofetil, which is Silcept, before surgery, at the day of surgery, at the morning before surgery, patient should receive 500 milligram mmF orally immediately before transplantation. After transplantation, 500 to 750 milligram twice daily. Steroids. Patient should receive methylprednisolone 125 milligram given once a day for the first 3 days after transplantation. Then we reduce the dose gradually to 0.4 milligram per kilogram prednisolone per day for 1 year, then decrease gradually to 0.2 milligram per kilogram every other day forever with the immunosuppressive treatment. Antifungal treatment, micafungin 100 milligram for 1 week after surgery, then we shift to itraconazole 200 milligram capsule per day for at least 1 year, but it could be extended to 5 years and could be extended forever according to the situation of the patient after surgery. Antinusitis cranii, patient should receive Ciptrine 1 gram per day for 3 days a week, at least 1 year or more. If intolerable due to its miserable side effects, patient should inhale 300 milligram pentamidine once a month. Physical therapy should be started as early as possible, especially after extubation of the patient after 5 days from the surgery. It includes chest expansion exercises, chest tolerance and cough training, core body exercises, and walking training. Special precautions in the transplanted patients, we should do cytomegalovirus, IgM and PCR once a week in the hospital during hospitalization of the patient with about 2 months after surgery, and Epstein-Barr virus, IgM, PCR every 2 weeks in the hospital. Thyroid profile, interleukin-2 receptors, antibodies 1 month after transplant, then repeated after 6 months. Also aspergillus antigen, itraconazole level, beta-glucan every 2 weeks during the hospitalization period. Also, donor-specific antibody 1 week after surgery should be done, then monthly for the first 6 months. Late post-operative follow-up, we have to follow guard against infection, rejection, and airway complication. Infection incidence of infection post-transplant is higher than other organ transplant due to immunosuppression, inhaled environmental microorganism, ischemic allograft complication, organisms like virus, fungi, bacteria. So the rule of surveillance bronchoscopy and the surveillance bronchoalveolar lavage at around 1, 3, 6, and 12 months post-transplant is a common and acceptable schedule to identify asymptomatic infection or colonization. Rejection, we have 2 types of rejection, acute cellular rejection and cell-mediated antibody-mediated rejection. Acute cellular rejection instance is 28.4% in the first year after transplant, higher risk factor for bronchiolitis obliterans syndrome. Treatment with increased immunosuppressive increase the infection risk, diagnosed by transbronchial lung biopsy. Transbronchial lung biopsy, as you know, should be taken by cryobiopsy. First biopsy, this is by forceps biopsy. It's a very small sample. Cryobiopsy get more bigger representative sample, easy for the pathologist to read the results. Second type of rejection is antibody-mediated rejection. If the patient has a clinical presentation or subclinical presentation. If it has a clinical presentation, we have to classify according definite, probable, or possible, according to the presence of one of 3 these parameters. Donor-specific antibody, if it's positive histology, positive C4D, which is a marker for T lymphocyte activity. If it's 1/3, 2/3, 3/3, classified according to these 3 categories. Treatment will be plasmapheresis, intravenous immunoglobulin, and rituximab. This is International Society of Heart Lung Transplantation consensus statement on adult and pediatric airway complication after lung transplantation. They stated a special grading system for airway complication post-operative. First is ischemia and necrosis. They classify location and extent. Location A, B, C according to the site of the ischemia and the necrosis, pre-anastomotic or extending more than 1 centimeter from the anastomotic area, or extending more than 1 centimeter from anastomosis into lobar or subsegmental airways. The extent also according to the percentage of the extent of the ischemia and the necrosis, either less than 50% or more than 50% circumferential ischemia, or less than 50%, 50 to 100 circumferential narrowing. As we see here in this picture, location here is A, pre-anastomotic within 1 centimeter, and the extent is A, less than 50% of circumferential ischemia. Also, in this picture, location is B, extending more than 1 centimeter from anastomosis to major airway, and the extent is D, nearly 100% of the airway circumference. Second is the dehiscence, classified according location, cartilaginous, membranous, or both, will extend to also A, B, C, D. In this picture, as you see, location is B, anastomosis dehiscence in the membranous wall. The extent is A. It's about 25% from the airway circumference. In this picture, location is B, also membranous, and the extent is D, more than 75% from the airway circumference. Stenosis, it's also classified according to its location, anastomotic, anastomotic plus lobar, lobar segmental only, and the extent A, B, C, D. In this picture, as you see, location is A, stenosis is at the anastomotic site only, extent is B, from 25 to 50% reduction in the cross-sectional area. In this picture, as you see, stenosis in the anastomotic area, and the extent is D, which is 100% obstruction of the airway lumen. Lastly, malacia. Location if it peri-anastomotic within 1 centimeter or diffuse involving anastomotic and extending beyond 1 centimeter. In this picture, as you see, malacia is A, malacia is peri-anastomotic within 1 centimeter. Here, malacia is diffuse involving the anastomosis beyond 1 centimeter. Management of airway complication shortly. Ischemia, necrosis, and dehiscence. CT finding, as we see, there is a bronchial dehiscence, as you see here, here, here. If mucosal necrosis only, surveillance bronchoscopy is a gold standard for confirmation of the diagnosis. If bronchial wall invasion with air leak, intercostal tube insertion, follow-up bronchoscopy every 2 to 3 days, decreases steroid dose, systemic and inhaled antifungal. Extensive necrosis, we should apply covered metallic stent to seal dehiscence or uncovered to promote neoepithelialization. Removed after 6 to 8 weeks after healing. Avoid silicone stent as it doesn't promote healing, and the shear force of its placement may enlarge the defect. Partial dehiscence, bronchoscopy with application of fibrin glue or alpha cyanoacrylate. Severe dehiscence, surgery for reanastomosis. Stenosis diagnosed also by surveillance bronchoscopy, as we said before. Commonest airway complication and common at bronchus intermedius, causing vanishing bronchus intermedius syndrome. Treatment is by balloon dilatation, always ineffective, least invasive, needs several dilatation, and usually in conjunction with endobronchial stent. This is after, this is before balloon dilatation. This is during balloon. This is after balloon dilatation, as you see here. Endobronchial stenting is debatable about timing placement. Should be avoided if possible. Considered in symptomatic patient require frequent balloon dilatation more than two times per month. Ablative therapy, including laser, cryo, cautery, brachytherapy, APC, argon plasma coagulation. Mitomycin C, it has a great role. It's an antifibrotic. Good result in recurrent stenosis. Surgical intervention, finally, surgical resection is not preferred for refractory airway stenosis due to immunosuppressive drug, long-term steroid use, post-surgical adhesions. Malacia is defined by reduction more than 50% in the luminal caliber with expiration, result from loss of cartilaginous support within the airway. These changes may occur both at the anastomosis and more diffusely throughout the donor airway. Dynamic inspiratory and expiratory CT is highly suggestive of malacia and the diagnostic. Surveillance bronchoscopy is the gold standard for diagnosis. Treatment, asymptomatic patient should not be treated. Symptomatic patient, conservative, pulmonary hygiene, non-invasive positive airway pressure, intermittent during day. Amount of pressure required should be determined by performing what's called dynamic bronchoscopy. Dynamic bronchoscopy is done while titrating non-invasive positive pressure ventilation, as we see in this picture. As you see, the picture here is the Malaysia reduction in more than 50% of the caliber after doing non-invasive and calibrating the pressure, increasing the pressure, the airway caliber increased to 100% during bronchoscopy. If failed, consider silicone stent, either temporary or permanent. Surgery may be an option for operable patients who improve after stent trial 10 to 14 days, surgical approach to dissection, reconstruction, or tracheoplasty. Lastly, this is a review article, an excellent review article by Professor Yoshida Te, published in 2017 in Journal of Thoracic Disease about living-related lung transplantation. He performed 124 cases of living donor lung transplantation, and they published not 5-year survival rate, not 10 survival rate. He published 15-year survival rate with 61.7% survival rate, 15 years. In conclusion, lung transplantation is a multidisciplinary team. Proper selection for candidate patient and donors, early post-operative focus on recipient physiotherapy and rehabilitation, long-term monitoring to the recipient to detect early signs of chronic rejection, strict infection control measures. Thank you for your attention.